Okay, so I would like to thank CGIS for giving us this opportunity to present our work here. I'd also like to thank the moderators and Dr. Pryor and Dr. Powers for also being my mentors. So this slide is just for disclosures. Dr. Pryor is a speaker for companies and a consultant as well. Dr. Spaniolis is also a speaker. This work was funded by the Department of Surgery, and there were no other conflicts of interest declared by the authors. So just for background, as you can see here, we have the family of appendix. But for the purpose of our study, we're going to focus on complicated appendicitis, which is defined as appendicitis with imaging findings of either a frank perforation or perforation with contained abscess. So the way that we usually treat these patients is with IV antibiotics. We put them on bowel rest and, we put them on bowel rest and then we let them recover and we bring them back for an interval appendectomy. And the biggest question that we're trying to ask here is, what is the optimal timing for interval appendectomy? Well, a lot of surgeons have looked at, bring their patients back after 6 to 8 weeks. There are some studies that have suggested bring the patients after 10 weeks. And even in the pediatric population, they've suggested to bring the patient after 12 weeks. So that was kind of like the primary question that we were asking. The other secondary question was, how about racial socioeconomic disparities? Do they relate to interval appendectomies at all? So that's kind of like the second question that we were looking at. So we conducted our study using the New York State Sparks database. And we used all the billing codes, whether ICD-9, ICD-10, and CPT codes to identify the patients with appendicitis. We excluded all the patients with either appendectomy in less than 1 week or more than 2 years. We also excluded patients who had their appendectomy in who were less than 18 years old, those who were in the unknown gender, those who are pregnant, and those who were in the hospital death. And finally, we got to our patients with interval appendectomy. And out of these, we broke down these patients into 4-time intervals. So the first 25% of patients had their interval appendectomy between 1 and 6 weeks. The second, between 7 and 9 weeks. The third, between 9 and 15. And the fourth, more than 15 weeks. And our outcome measures were divided into primary, secondary, and tertiary. So for our primary endpoint was the length of stay, which is a measure of resource utilization. Our secondary endpoints included our 30-day readmission and perioperative complications. And that included either bleeding, wound infection, C. diff colitis, or open to a conversion procedure. And finally, our exploratory endpoints included 30-day mortality and colonoscopy findings of either inflammatory bowel disease and inflammatory bowel disease or neoplasm, or 30-day mortality. So in the summary of our patient population, we had a total of 5,069 patients who had an interval appendectomy. Out of those, 20% had a percutaneous abscess drainage. The median time to interval appendectomy was 9.2 weeks, and the median age was 48 years, with almost 50% of these patients being females. Then we wanted to look at the time interval and the length of stay. And interestingly here, we found that patients who had their interval appendectomy between 7 and 15 weeks had a significantly lower length of stay compared to the patients who had their interval appendectomy between 1 and 6 weeks or more than 15 weeks. This is a busy slide, but based on the univariate analysis here, as you can see here, patients from ethnic minorities, whether they're Asian non-Hispanic, Black non-Hispanic, Hispanic, or others, had a significant had their interval appendectomy at later time intervals, particularly after 15 weeks. We also found similar findings in the patients who had either Medicaid or Medicare. We also found that patients with percutaneous abscess drainage had their interval appendectomy at later time intervals. On regression modeling, we found that patients who had their interval appendectomy, again, between 1 and 6 weeks, to have a significantly longer length of stay compared to the patients who had their interval appy between 7 and 15 weeks. On the other side, we found that patients who had their interval appy between 7 and 15 weeks to have a shorter length of stay compared to patients who had their interval appy at greater than 15 weeks. When we looked at the abscess drainage, we found that the patients with abscess drainage had significantly longer length of stay. And only the Black non-Hispanic patients, after holding all variables constant, are the only ethnic group that have a longer length of stay. But for insurance, all patients with non-commercial insurance, that including Medicaid, Medicare, and those who are uninsured or those with self-pay, which were described as other, had a significantly longer length of stay. For our secondary and tertiary endpoints, which included either 30-day readmission, perioperative complications, 30-day mortality, and colonoscopy findings, we found no differences or association between these variables and the secondary and tertiary endpoints. So, I think we skipped going back. Okay. So in conclusion, our study aimed to look at the optimal time interval for interval appendectomy. And our study showed that interval appendectomy between 7 to 15 weeks is the one that is associated with the least length of stay. And we also found that patients who are from ethnic minorities and those with non-commercial insurance to have their interval appendectomy at a later time endpoint and also had a longer length of stay after their interval appy. So where do we go from here? I mean, our study had 5,000 patients. It's robust, but it's retrospective. So moving forward, maybe we can use prospective or randomized trials to look at the association between interval appies and adverse outcomes and resource utilization. Further, we can dedicate studies to primarily look at interval appendectomy and its association with health disparities and differential access to care. That's all I have for today. Thank you.